We don't want to compromise quality and patient safety with efficiency. Okay, so it's very important, again, that we complete an accurate assessment and know every step that the physician and nurses are taking. Again, removing those non-value added steps, those duplications. Communication is key. In real estate, they say location, location, location. In our environment, it's communication. The physicians and each discipline must communicate each step of the process. We also have to include the patient so we can decrease the patient's anxiety. Our patient satisfaction scores are key. And since we've been here, our patient satisfaction scores has increased drastically from 51.9% to 86.9%. And I think that's a huge win. What that means for us is that the patients are responding to the process changes. But they do feel the change. They do feel that they're being treated immediately. And that's key, right? Remember, time is of the essence. Time is tissue. Time is muscle. What does that mean? We have patients coming in having a heart attack, STEMIs, strokes, right? Sepsis. Time is everything when taking care of those patients. If we don't jump on them timely, then we have poor outcomes. So efficiency is definitely a priority, but it's still important to note without compromising our quality. We do have a national shortage of nurses and physicians. And so physician extenders is key in this case. Remember, most of our patients are coming to the hospital to see a physician. And so how can we better support physicians? Then you use physician extenders, you use nurse practitioners, you use physician assistants. And in our model, we're using nurse practitioners. And so that lends a helping hand to those least urgent patients. We have 5 levels of triage that we use here. Number 1, we're basically resuscitating you. You need to see a physician. Number 2, if we don't do something, those STEMI patients, those stroke patients, those septic patients, we will be resuscitating. You need to see a physician. Number 3 is key. Those are our longest length of stay patients. They come in with chest pain, abdominal pain. We have to rule out cardiac. We have to rule out whether this patient is having a heart attack or not. And then with your abdominal pain patients come multiple diagnostic tests, right? And so how can we process those patients? That's back to those vertical 3s, those patients that do not require a bed that we can treat in a nice recliner while we're running their diagnostic test, right? And so that frees up the capacity of the emergency department. It increases the capacity of the emergency department, allowing us to see more critical patients in those beds and giving those patients that dedicated time at the bedside.